The Office of Total Worker Health and Safety at the National Institute of Occupational Health, Safety and Health, part of the Centers for Disease Control and Prevention. Please welcome Dr. Chosewood.
Thank you. It's a short drive, but it is a beautiful drive and reminded me of my home. You know, I live in Atlanta now in a pretty chaotic part of town, lots of traffic, lots of loud noises and fire trucks at night. But I grew up in the mountains of North Georgia. So coming back to this area, seeing the nice rolling hills and all the farms and the beautiful fenced pastures and the horses in the distance, it was really almost a trip back home. So thank you guys for that. So that memory, I don't get home enough. It is my pleasure to be with you today. I will give you just a little bit of information about CDC's current portfolio in NIOSH, and then quickly move to talk to you about something that I feel quite strongly about and quite personal and passionate about, and that's workers. So you guys know CDC is based in Atlanta. We're the only federal agency that's not based in the Washington, D.C. metro area. That might surprise people to know. All the other federal agencies are based in either Virginia, Maryland, or Washington, D.C. We're in Atlanta because, well, first of all, they don't want our dangerous laboratories anywhere near Washington, D.C. We have, as you guys know, the only actual live smallpox virus in the world, except for one other lab in Russia. So we have some pretty dangerous pathogens there. All the Ebola work, the live smallpox work, all of the hemorrhagic fever viral work is done in Atlanta. We're there, though, because when CDC got its start about 75 years ago, we were specifically in charge of getting rid of malaria that still existed in the southeastern part of the United States. So we were positioned in the southeast because of our first mission, sort of as a public health response agency. And we've just continued to remain there throughout all the time. So we have about 16,000 people now working at CDC. It's quite a large number. About 10,000 of those are full-time government employees, and then another 6,000 or so contractors who come and go depending on either the emergency, the funding level, the challenges of the day, the responses that we're involved in. You probably most know us for things like influenza response, infectious disease outbreaks, vaccines for children. Those are huge parts of our budget, but they actually are only about 1/10 of the organizational structure of CDC. So CDC stands for centers, and that's because we have a number of different centers, including an infectious disease center, but we also have centers related to environmental health, chronic disease prevention, developmental disabilities, injury prevention, it's a big one, and the center that I'm part of, the National Institute for Occupational Safety and Health. We're one of the 10 major centers within CDC. NIOSH has about 10% of the workforce population at CDC, so we're fairly well staffed and positioned to improve our research and understanding of occupational safety and health issues. We have about 1,500 workers, about 1,000 or 1,100 are full-time government employees, and then a number of contractors as well. NIOSH, unlike the rest of CDC, has its headquarters in Washington, D.C. So my boss, John Howard, sits in Washington, and that's largely because we have such close ongoing dialogue and relationship with the Department of Labor. So we're very much a sister agency to OSHA, right? So OSHA is within the Department of Labor, we're within the Department of Health and Human Services. Our institute does much of the research and the implementation of that research and understanding of it in the field that will eventually make its way into regulation that's enforced by OSHA. So almost all the research that underpins an OSHA regulation has been done by NIOSH. That's sort of a very close ongoing relationship. We also have a number of programs that you might not automatically think of as related to occupational safety and health. For instance, about half of the NIOSH budget, which has grown substantially since 2001, is dedicated to the World Trade Center Health Program. So we follow about 100,000 people who were exposed either during the terrorist attack itself or in the cleanup of that terrorist attack. And we have funding for 75 years to follow those people throughout their life and provide for any health needs that they may need, including compensation for any diseases that they acquire and coordination of their health care. That's quite unusual. We're basically operating an insurance company, a very well-informed, research-based insurance company that manages the health of this large population. NIOSH was chosen to do that because we're quite trusted from both the private sector, the business community, as well as organized labor, which is quite heavily involved in the negotiations around health care benefits for these people who were injured in that attack and in the cleanup. So that represents quite a bit of our budget. That's one of the things that most people wouldn't say, oh, that's what NIOSH is doing. That's a huge part of our portfolio. Another significant part is our testing and sort of accrediting of personal protective equipment. So all of the gloves, the gowns that are used in hospitals, all of the respiratory protection, all of the turnout gear that firefighters use, all of the really any protection that someone might wear on the job that needs to be certified as actually able to protect workers, all of that certification is done by NIOSH. We have laboratories in Pittsburgh that really test the quality, the durability, the reproducible safety, health effects of tons of different types of protective equipment. We do still quite a bit of mining research for the nation. So even though mining is less and less a component of the economic engine of the country, we still do quite a bit of it because it's one of the more dangerous professions that's out there. We've seen a resurgence of silica-related and coal dust-related lung disease in this country. Still, there are parts of the country, including Kentucky, where we see major problems still with black lung related to coal mining. We've had an increase in our portfolio related to oil and gas exploration. That's a growing part of the U.S. economy, a very important one. The U.S. is basically energy independent now, not dependent on the imported oil. We are becoming a net exporter of energy in this country. So it's a growing, important sector for NIOSH to be involved in. We have a Western States office that has really grown and really developed in part because of that challenge. We also, in addition to the mining work done in Pittsburgh, we have a very large presence in Morgantown, West Virginia, where we do research in the health effects of really any kind of workplace exposure. We have animal laboratories there, a lot of in vivo laboratories, human studies underway in West Virginia looking at health effects of all types of work exposures. And then the last area of NIOSH I'll mention is our Pacific Northwest action. We have a laboratory both in Anchorage, Alaska and in Spokane, Washington. And they're looking at some of the high hazard work in the Pacific Northwest. Anybody want to guess what the most dangerous job in the U.S. is right now?
Fishermen.
Yeah, fishing and logging. They're at the very top of the list. Really quite prominent in the Pacific Northwest. Also on that list, airline pilots' deaths. You think, gosh, I thought Delta and American and United were pretty safe. Well, we're not really talking about those big airlines. We're talking about the small transit planes that have to fly into really difficult locations because of weather, inaccessibility, storms, that sort of thing. That also remains one of the deadliest jobs in the nation. You've seen some of the TV shows, Deadliest Catch or Ice Road Truckers. Those all really represent the most fatal jobs in the nation. So we have quite a bit of interest still in driving down the disproportionate number of fatalities in a few occupations, right? Since our founding, NIOSH has reduced the number of workplace fatalities dramatically, more than half per year, die on the job today than when NIOSH got its start, despite the workforce being twice as big. So that's a significant change. Of course, it's not all NIOSH work. It's really a concerted effort from safety and health professionals like you to make workplaces safe. My team at NIOSH is dedicated to the concept of total worker health. And in a nutshell, that means that workers are not a work self and a home self. They're one self, right? You don't turn off all of the challenges and the issues that you face on the job when you walk into the parking lot and go home. You carry a lot of those challenges with you into your home, right? It might be rough day, snap at the first person I see when I walk in at home, right? Or maybe something more dramatic. I sit all day as a long-haul truck driver, maybe for days on end. I don't have access to high-quality food. I'm shouldering the stress of the chronic vigilance of having to remain awake for long hours, immobile, and I take home with me a 70 to 90% chance of obesity. Now, that's not an exposure that just limits itself to the workplace. That exposure that I carry home, that take-home benefit of obesity, and about 80 to 90% of truckers either are overweight or obese. 70%, the vast, vast majority, are obese. It isn't because only obese people line up when there are job openings, right, for trucking. It is part and parcel of the job description. You will become obese if you have this job long enough. And you will die an early death because of the job you have. So because we're not a work self and a home self, we believe that it's important to take a very comprehensive view of worker safety and health interventions. Workplaces are not just places where you can promote better habits and better understanding of what diabetes is and what I should eat, and while we love the diabetes prevention program that's really evidence-based intervention in workplaces to prevent diabetes, it's running after the cat's out of the bag. It's chasing the cat. We're interested in building a stronger bag so the cat never gets out, right? So how do you do that? A lunch and learn on diabetes is not enough to prevent the obesity that truckers get. You've got to redesign that work. And the redesign of that work, the whole examination of the schedule, the work demands, the stressors that are part and parcel of that work, is really the domain of NIOSH. We understand how work can be designed to be healthier and safer. We understand the hierarchy of controls as it comes to what are the predisposing elements, not of that individual, but of the job, when it comes to whether or not this person will do this job for a lifetime or a decade and become obese. So that is really, in a nutshell, what total worker health is. If you want healthier workers at the end of the day, yes, you need to give them skills that inform them and screen them for health conditions, but you also need to examine what is it about the job, the pervasive, expansive, overwhelming exposure that they're actually getting 8, 10, 12 hours a day, because that's where the risks are coming from, right? And I would argue that those risks are far more powerful than how much TV they watch at home, far more powerful than what they pick up in the drive-thru on their way home from work, because those exposures are accumulated over a lifetime, and they're pervasive and long-lasting, and if you don't attack that, then we're not going to absolutely impact the safety and health of workers. We also make a big deal in total worker health about the connection between health and safety. Most organizations still isolate those two efforts within their organization. Health, for the most part, has been dismissed to the domain of the human resources folks, and safety to either the line management or the production folks. And sometimes never the two intersect at all. We see a huge connection between health and safety. Safer workers are healthy workers, vice versa. So we put a lot of emphasis on the integration of those two programs within organizations if we want to get the biggest bang for the buck. So with that, why don't we go ahead and get started? Oh, this lets me take a break and reset and calm down a little bit. I get kind of like a revival preacher sometimes, so sorry for that. To remind you that it really hopefully is going to be a personal story here, a personal connection with the work. Why I think this is such an important opportunity for us as safety and health professionals, public health professionals in the room, to move in this direction. So this is Lily. She's my oldest granddaughter. I have a new one that's not made it to the slides yet, but she will soon. Lily is 6 years old now, and if you say, Lily, what do you want to be when you grow up? She will say, Papa, I want to be a princess. Like, oh. Well, honey, there's not much job future in royalty, okay? There are only a scant number of job openings every year for that, maybe not even every year. Do you have any other ideas? So we're still working on those backup plans. But I oftentimes wonder what kind of job Lily will actually have and what kind of work or workplace she will see in the future. And we'll spend a little bit of time talking about the future of work, because I think that is, if we want to be ahead of the next generation of work and workplaces that are created, now's the time to do it. And it's much easier to create a job from the beginning than to redesign or again, run after a job that's already going down the track. And if we're going to create a lot of new jobs in the next 2 decades, as is predicted, now's the time to be thinking about the design of those new jobs and what their health impacts are. It's easiest to do it now. I think we also have an opportunity to spend more time looking at this now, because workers in general are in short supply. And if there's ever a time when organizations are really interested in improving working conditions, it's a time when labor's in short supply. They want to enhance work so people stay and not go on to the competitor that's paying $1 more per hour or offering better benefits or less work demands for the same level of pay. So now's the time, I think, an easier time now than a decade ago to make some of these improvements in the way we do work. If any of you are grandparents, you already know this already, but for those of you in the room who are not grandparents and you're contemplating it, I say go for it, okay? Now, parenthood, on the other hand, I'll leave that to your own decision making. That's not necessarily endorsement of that. We've already touched on some of this, but I would argue that perhaps work is the most powerful exposure that people have in their whole life when it comes to health outcomes. It's certainly far more powerful if you look statistically than genetics. It's increasingly shown to be more powerful than health choice making. Work is just such a pervasive exposure. There's perhaps nothing that adds up to more hours of exposure than working conditions that people face. Right? Can you think of the next most common exposure that people would get beyond work? Sleep, right? And the wealth of information related to the quality of sleep and health outcomes, the lack of sleep, either the duration, the quality, the onset, the recovery from lack of sleep, all those things we know have huge health impacts now. Work and sleep, to me, are perhaps the most understudied, but yet most important exposures that people face. And why is that? We tend to invest money in prevention when we already see a health outcome, right? So we have a lot of money in this country spent on heart disease, oftentimes tertiary interventions for heart disease like stents and bypass. 97 cents of every healthcare dollar in this country is spent on providing care instead of preventing illness in the first place. So you all know in public health we get 2 to 3% of the healthcare spending in this country. Should really be about 50-50 if you think about it. And if we did a much better job on the front end, we'd need to spend far less on the back end. There's this whole idea of compression of morbidity. And you keep people as healthy as possible as long as you can, and you compress the actual amount of time that they're sick at the end before they die. And that really only works if you have a strong investment in prevention up front. Work is one of those things where you will pick up and leave everybody you know, everything you own, all the friends you've developed over a lifetime, and move 1,000 miles away. Can you think of hardly any other exposure, choice that would make you do that? But people commonly do that. People leave their support networks, their families, their homes, their status, their communities, and move all the time for another job. That has significant community and social and psychosocial and behavioral impacts on the individual. We talked about sleep. I would also argue that while sleep is a very important exposure, the type, timing, quality of your sleep is usually strongly dependent on the job you have. And we have this greater understanding now of the connection between work and sleep, between schedules and health outcomes, and we'll get into a little bit of that as we go through. Another argument for total worker health, keeping the whole worker in mind instead of just on-the-job worker and off-the-job worker, is this issue list right at that intersection of the blue and the red, the home and the work. Those issues bleed over and spill over constantly, and they can be some of the most challenging for individuals to navigate or for organizations to actually manage. I put this slide in, again, because of the Kentucky connection to coal mining and to other types of mining and to the persistent issues around lung disease, but also to bring up another significant hazard that we're facing. And that, in this state, along with quite a few others, is the challenge of opioid overdose death. So opioid addiction and death. And you say, well, okay, but that really has nothing to do with work. I'm going to ask you to reconsider that. And I will have a few slides later on that really draw a strong connection between the opioid crisis that we're experiencing today and working in economic conditions that we believe were a very strong antecedent into the current outbreak. And, by the way, an important leverage element to intervene to help reverse it. So we'll talk a little bit more about that. This graphic is pretty busy, but it basically shows us that we're not doing a very good job of estimating the risk that we face from work. So above the line is above the black horizontal line across the middle, is our perception of risk. And underneath it is the actual risk faced by us from that same threat. So the big blue circle on the left is our perceived risk of a terrorist attack. The actual risk is that tiny blue dot below. So we believe it's much greater than it actually is. Now move to the other side of the slide and you can see where we underestimate risk. So our estimation of work is that white circle all the way to the right. The actual risk we face from work is that much bigger. In general, we underestimate the risk that arises from the work that we do. Not a big surprise to probably many of you. So I've already started answering some of these questions for you. I would absolutely argue. And we have proof now through like the BRFSS, the National Health Interview Survey, that some of you've talked about already, that there are certain industries and occupations that absolutely shave years of life off people. It certainly ups the ante for certain chronic disease risks. For example, if you're a long-haul truck driver with that 90% chance of becoming overweight or obese, you're having significant challenges with chronic disease. About half of workers report on the job every day with some sort of chronic disease. Anyone want to guess what the most common chronic disease that people report to? Hypertension would be a good choice, some kind of vascular disease, heart disease would be a good choice. But joint pain, arthritis, is the most common chronic condition that people report to. And quite interesting that day in, day out pain has a number of other spillover health effects, right? Not only increasing the risk for addiction, opioid misuse, opioid use disorder, but spillover effects into a tremendous number of mental health issues. So if you have daily chronic pain, your chances of depression go way, way up. Yeah.
How much of that chronic pain is from diet?
Yeah, great question. How much of that pain, especially when it comes to weight-bearing joint disease, right, is related to diet and obesity? That's a good question. Was your angle specifically around obesity or another angle around diet?
No, I mean, you mentioned joint pain and
Yeah.
I know you mentioned also that these truckers don't eat very well.
Yep, exactly.
So I think that would be a large contributor to joint pain.
No doubt about it. The weight-bearing joints are heavily impacted by obesity. And that's specifically responsible for the surge in knee replacements that we've seen in the country and hip replacements, right? Directly related to the nation's obesity crisis, no doubt about it. Added into that, though, and speeding up that trajectory between normal knee, diseased knee, replacement of a knee, is oftentimes working conditions, right? We see differential rates of joint replacement depending on the job people have. It is not uncommon for a construction worker in this country to be disabled from work in 2 decades. 2 decades, right? And that oftentimes is a combination between environmental exposures, the type of work demands that come with construction, as well as the lifestyle and the choice-making demands that lead to some of these chronic health conditions. But there is a strong association between certain jobs and early disability, early departure. Construction perhaps is at the top of that list. Great question. We've already hinted about my chances of being overweight or obese being strongly work-related. We'll come back to that in a moment. Shift work. So many of you have shifts as part of the sort of landscape around the work that's done in your organizations. Certainly true for fire, police, for healthcare workers, but increasingly all industries have more dependence on shift work as we move to a global economy. And I would argue that those of you who carry home a smartphone are engaging in shift work as well. If I were to say how many of you have work-related interactions through a device with coworkers, colleagues, or doing work at home after hours, it's virtually everybody. So there's this sort of disconnect between being on the job and away from the job. And even though you probably don't account for it, there's a level of increased stress that comes with that responsibility. Whether it's real or perceived or self-imposed, it's nonetheless leading to some sort of common, probably oftentimes revisiting some pain points during the day when you get back on the smart device, right? We're increasingly seeing this connection between conditions of work that lead to stress and poor health outcomes. So we have a 30-year research program on work stress, and a lot of people say, well, yeah, everybody's stressed, right? Or a little bit of stress is good for you. It helps keep you competitive. It pushes you to do greater things. Maybe some of that's true. But in general, work stress is responsible for a huge amount of lost productivity, of absenteeism, of healthcare spending, of predisposition to work or injury and illness. We see work stress really well studied by some of the best occupational health psychologists in the country as a major health threat. And I would argue that a lot of the poor health outcomes we see in some industries and occupations have sort of a common pathway of moving through workers from their job to a high-stress situation, and that high-stress situation leading to chronic health outcomes. Good example is a bus driver study in Los Angeles that showed resting blood pressure went up 10 to 15 points when the worker stepped onto the bus each day. So baseline blood pressure, X, you step on the bus and start driving. Within 15 minutes, blood pressure resting up 10 points. Over a decade, that's devastating to the vascular system. That absolutely increases cardiovascular risk factors, stroke risk factors, no doubt about it. And it isn't necessarily because they were lifting or they had heavy demands related to the work. They were bus drivers. But the stress of chronic vigilance, the stress of being worried about interacting with the public, the stress about causing an accident or injury, hitting someone, a pedestrian on the street, all of those things carry some risk. Now, I'm not here to say work can be stress-free, but there are interventions that we can do to help decrease that exposure. And I think that's an important area of research for the future. This was also getting to your question, sir. How does work impact choice making? Perhaps the best insights we have to that come from the BRFSS, the Behavioral Risk Factor Surveillance Survey, or system. This system, for the first time, just maybe in the last decade or so now, in about half of the states in the country, ask some pretty important questions. Yeah, we're going to ask about your sex life, how much you drink, how much you smoke, how physically active you are, what your diet looks like. But we're also going to ask another important question. What is your job? What is your occupation and industry? And now that we can look at that data, nationally representative, and show that there are risks and behaviors that are much more common in one job than another, all of a sudden it's less about the individual and a lot more about the environment of their workplace. And that really is where we've come up with this statement, that work is a strong influencer in a lot of choice making. What we say is, oh, just purely individual? Clearly there are some work-related drivers and guardrails and directional signs that are pushing people in one way or another. Good example is tobacco. Tobacco use is not uniform across all industries and occupations, even when you control for things like education and income. So you think, well, some jobs are going to have more low-wage workers, so of course you're going to see more smokers. Control, get out that. Control for education and income. Still, we see higher rates of tobacco use in some industries and occupations. Some are environmentally influenced. If you're an outdoor worker, your chances of being a smoker are about twice that of someone who works indoors. So it's the permissiveness of the outdoor space, right, that is leading to that. Or the peer influence, where some workers are able to smoke more, they see others smoking, they see maybe the break that comes from that tobacco use, and that pushes people into tobacco use as well. So there are definitely work influences, industry and occupation differences, and a number of health risk factors. Heart disease risks are different. We mentioned tobacco risk being different. Certainly musculoskeletal concerns are different. We mentioned construction there already. Does it surprise you that the most obese of all occupations in the U.S. are police officers, firefighters, and security guards? Yeah. When I ask the question, where's this coming from? And invariably somebody hollers out donuts, right? I would argue, and our research shows that it's not diet related, that while that may be part of the issue, it's probably more related to long hours of work and shift work, to this stress of chronic vigilance, to this multiple jobs that oftentimes are part and parcel of fire and police, right? It is not uncommon for a police officer to work more than a 40-hour shift for a municipality and then have a security job, oftentimes authorized by the municipality itself on the side. So when you have a job that demands 80 hours, then it is no surprise that your health takes a back seat, right? Your prevention activities like physical activity, choice making around diet, those take a back seat. Question?
Is there any research, particularly among social work, police officers, other those kind of fields, connecting those outcomes to secondary trauma?
Yeah, interesting. Secondary trauma, meaning like adverse childhood experiences?
No, not ACEs, but more like from dealing with trauma, secondary trauma.
Gotcha. So the exposure of the job itself. A social worker who hears really difficult stories about the challenges that are other facing all day, or the firefighter who's revived their third person on a shift from an opioid overdose, or the police officer who has to go into settings of domestic violence or deal with really difficult, challenging circumstances. There is a little bit of early research about that, but it's certainly not studied well. And while we probably have some early data showing the early health impacts of that, the psychosocial stressors, perhaps maybe some of the mental health outcomes, I don't think that I've seen anything in the research that looks at chronic disease outcomes related to that. So probably some acute findings related to that secondary trauma. There's an increasing amount of literature around PTSD in police and security work. So it's a really great question and an opportunity for more research. Thank you for that. Not surprising, though, that there's some jobs that do pretty well when it comes to obesity also. You see some of those that really prioritize physical fitness as part of the job, athletes, actors. There are other few on here that do quite well. Economists, scientists, and psychologists. Yeah, interesting, huh? If you look, there are some studies that show the healthiest population in all of the country are college professors. And I would argue that it's probably they're quite a bit of time off, right? Yeah. Quite a bit of autonomy from time to time. Here's the other thing, though. The amount of control you have day in, day out on your work is hugely important. If you have no autonomy, no decision-making in your job, your health almost invariably is going to be poor. If you have a lot of flexibility, a lot of control over when you start your work, when you finish it, the order you do your work in, you have a voice, so to speak, in the job itself, health improves dramatically. And some of the interventions that we've talked about in Total Work Health really come down to that. We have good examples of manufacturing companies now that allow their workers to have a 2-hour window when they start and stop work. So if it's more convenient for their family to start work at 6 a.m., their shift allows that. If it's more convenient for their family and personal situation to begin work at 8 a.m. instead of 6, this job allows for that. So that kind of intervention, that kind of just giving people a little bit of freedom to help make some determinations about what works for them is strongly important when it comes to controlling some of these things. So all of these findings have led some to say that if you want to fix fat workers, you have to fix fat jobs. Because there are jobs that absolutely predispose to obesity. Does this sort of take away all personal responsibility? Absolutely not. There's nothing that we do in safety that doesn't have some level, some element of personal choice making and decision making and personal responsibility. But if we really want to change the obesity epidemic, it's going to take a lot more than just that. It will not succeed without backing upstream and saying, what is it about people that is influencing their decision making? What is it about their environment, their circumstances? And if we really want to fix things, it's much easier to do it at the society level instead of one-on-one. We're going to talk about a number of other jobs and some of the challenges that people are facing. Here's some that are quite common in your setting, and I picked these specifically because of the industries and activities that are popular here. I grew up near Habersham County in Georgia, near the poultry capital of the world. So just the whole landscape was dotted with poultry farms and chicken houses, and of course you have to have processing plants that are related to that. My first job, apart from cutting grass for the neighbor, was in a poultry processing plant. And my job was to take frozen chickens at a rate of about 20 to 30 per minute and pack them into a box. Not only was, you quickly got some musculoskeletal complaints, but your hands were frozen cold all the time. I don't think we were offered any gloves or any personal protective equipment. We did a lot of this when we were breaking. But it was a job that obviously made me study very hard to get into medical school, so did not want to go back to the chicken plant. You say, well, we don't have a big mass number of taxi drivers driving around this part of Kentucky. In truth, you do. They're called Uber drivers, right? And Uber is not only Uber or Lyft or Uber Eats or all the other delivery services, or the Domino's was the first Uber Eats, I guess. But it's also all the package delivery, now increasingly done, right, by independent contractors, gig workers, people who have a second job. So this represents another really changing dynamic when we're talking about the exposures that work involves. It's not only what we do day in and day out, it's how we're employed. The nature of that employment relationship is also quickly becoming something we can measure as an important health effect. We'll talk a little bit more about that. Workforce is getting older. You can see the most rapidly growing segment of the workplace are those workers not over 55, not over 65, but over 75. That is the fastest growing segment of the workplace. So a McDonald's, you might have seen this on TV, has one worker who's 15 and one worker who's 92, right? So not only 5 to 6 generations of workers in the workforce interacting, but an increasing number of older workers. And people stay on the job for a number of reasons. In some ways, it's a success story because people can stay on the job into their 8th, 9th, 10th decades of life. That's a success story that we've gotten rid of some of the hazards of work. It also oftentimes means that people are forced economically to stay in the workplace. In general, the youngest workers and the oldest workers in an organization are the most at risk. Youngest workers because they don't have the experience, training, judgment. We also know that they don't have adequate exposure to personal protection and safety training. Older people, not because they are more accident prone. In fact, if you look at non-fatal accidents, older workers are not prone to more accidents. But unfortunately, they are more prone to fatal accidents. And when they do have an accident, their risk of, or the likelihood of return to work is very, very low. And the cost associated with that, the downside, the disability, the spending related to that accident in older workers is much higher. They are not the most accident prone of all workers, however. That would be the young workers. If you look at workplace fatalities, there is a bit of a bathtub curve. I mean, high at the early onset of work, low in the middle, high at the end. And those are fatal injuries related to work. So we'll come, question?
If you could go back to
Sure.
the previous slide, I guess it's just kind of almost alarming if we look at the age from 25 to 54, 2.4% of the workforce. What do you attribute that such a low rate in terms of younger people in the workforce?
Sure. Almost all these changes are demographic, meaning that we just didn't have a lot of people born during that segment compared to the baby boom segment. We're seeing changes in the birth rate, though. These are projections, so these are projected percentage changes in labor force by age. It's not representative of current true total workers. If you look at what the most common worker is a millennial now in the workplace. That represents the biggest portion of workers right now. So these are percent changes, so it might be a little misleading in the way this is presented. This is not the total number of workers across the working force. So here are some policies that our Total Worker Health program would say are really valuable if you want to create an age-friendly workplace. And again, at the top of the list, workplace flexibility is extremely important. Other things though, like accommodating medical self-care in the workplace. So people now will have a medical break room where people keep their diabetes testing supplies, their medications, their special lunches or in refrigerators there. So they will have accommodations where people who have chronic disease can manage it while they're at work. The other important thing I'd take away here is don't forget the opportunity you have for cross-generational mentoring. We, in our organization, have a new program where older workers really do a lot of culture building for the new workers who come in. And we try to pair an older worker with a new worker. And vice versa. Some of our new workers will help teach the old workers things like social media skills, or sort of new communication approaches, or new computer programs that would help make their work, their data mining, their data management, their paper writing, their collaboration skills online with certain tools. The younger workers will help mentor our older workers. So I think there are really some nice interventions that we can take away from this. We've already talked about some of those chronic diseases known to be related to work, but some of these might surprise you. 10% of lung cancer related to work, almost all of mesothelioma, as you guys know, a number of other cancers there on the left. But take a look on the right. Up to 1 in 5 cases of heart disease thought to be related to work. And heart disease, is the leading killer of Americans, certainly true for Kentucky. About 700 to 800,000 people a year die of heart disease. 1 in 5 of those can be tied to conditions of work. This is an important study, again, looking at people like the connection between obesity, the connection between blood pressure changes, other work stressors that predispose to heart disease. Some of the bloodborne pathogen work, not a surprise in healthcare settings. Hearing loss, about 10%, also probably not surprising to many of you. Lung disease, though, heavily represented on this list. So asthma, COPD. There's still quite a number of respiratory hazards that workers face. We hinted about the future of work and new jobs on the way. If you look closely at this long-haul truck driver in Nevada, this is an actual photo, not pretend, not staged. This is a long-haul truck driver who's using an iPad to take a break from driving. Still going down the road 60 miles per hour, and he's using an iPad to look at a YouTube video or a movie. And this is an autonomous vehicle. So this vehicle is designed to drive itself. It's being studied in Nevada, right outside Las Vegas, and has been shown to be quite effective. Not only in safely getting the materials and the person from one place to another, but also some behavioral studies and some health studies done in this setting have shown stress levels going down, people feeling less fatigued from their work, feeling less challenged from their work because they can take intermittent breaks. And it really gets to that exposure of chronic vigilance, having to be on, alert, looking around you, having to be in charge and control at every moment of the day. And lots of jobs like that, right? Lots of jobs in healthcare like that, certainly police and firefighting oftentimes like that. That stress of chronic vigilance is a common pathway, we believe, for workplace stress and risk factor for chronic disease. But this kind of intervention may be our solution to the 80% obesity rate in long-haul truck drivers, right? Another intervention we've heard of is, and these are in trucking companies that have workers who leave in the morning, do deliveries within 100 to 200 miles, and come back at home at night. Those workers are now having their lunches packed for them by the company in a big cooler that sits with them next door. So not only are they, it's a benefit, you don't have to stop at the McDonald's, but the food quality is improved. So their food choices, food quality, right protein match, enough hydration is provided for them handy there in the cab of the truck. And that's given to them every morning before they depart. So that kind of intervention, along with probably better attention to shifts, shift is a really hard hurdle to cross over in transportation. Long hours, we know have significant health and safety impacts, but it's going to be a very difficult change to make. But some of these other interventions really look quite promising. The prediction is that just about every new car sold will be autonomous or semi-autonomous within the next decade. So it's very likely that the next car you buy will have many of the features of either autonomous or semi-autonomous driving. And in 2 decades, universal. There will be no cars made that are not autonomous. Car ownership is expected to go down. We're already seeing that. In Atlanta, car ownership has dropped dramatically. I live in a fairly busy neighborhood where a lot of my neighbors have Uber come pick them up and go to work, pick them up and go to the train station, pick them up at night and go out to dinner. It's going to become increasingly possible. When you have an autonomous vehicle, there will not be a need for an Uber driver. So you will use the Uber app and the car will show up, but there will be no driver. And you will get in the vehicle and it will take you to the bar and to the restaurant, and it will do the same when you're there. You think, that's crazy. In Pittsburgh, that test is already underway. So the autonomous Uber system in Pittsburgh, Pennsylvania, is completely autonomous now. They still have a driver in the cab, but the driver is just sitting there. The driver's not doing anything. It's a test, pilot test in the city of Pittsburgh, but it is currently underway. And the belief also is that you will be able to commute to and from work that way as well. So you will not necessarily need, and it might stop along the way and pick up other people headed to the same destination as well. If you've done Uber Share, you've probably seen that kind of approach already.
What's the impact of the stress on the passengers?
Yeah, who's driving this car?
Who do I have to share it with?
Well,
Great questions.
I think that's a good, that's a good point. But we're still not taking a lot of vehicles off the road, so there's still a lot of opportunities for, rental cars.
Right.
When we have a program here called Safe Communities America in a lot of communities in Kentucky and several around the country, and one of our communities is working on West Virginia. They have a nice little monorail system. What are the thoughts about expanding something like that?
Right. So for the recording and those who didn't hear, the question is, what about better public transit options, right? Sort of like monorails or public trains. And yeah, I think those are, if the infrastructure exists and we have the right kind of investment to really grow those common resources, I think there's significant advantages, especially for really heavy urban locations. It's maybe not a solution for everywhere, I mean, obviously a rapid transit system here might have more challenges than in an urban center, but I think it has to be part of the overall equation.
Are there factors other than stress, diet, and sedentary that affect, any other than those three that affect?
Absolutely. So the question was, are other jobs, other than the ones we mentioned already and talked about quite a bit, they're impacted by sedentariness, access to diet, other conditions of work that might be predisposing. Those are certainly some biggies, the ones that we've mentioned already.
Stress, obviously.
Yeah, and workplace stress. The other place we see a lot of challenge is in healthcare. And for a number of reasons. Healthcare is a growing and large part of the workforce. Healthcare is oftentimes the largest employed segment in any community. And that's increasingly becoming true in more and more communities. That will change as the population has some shifts, but right now healthcare is in high demand because of the baby boomers, high consumers, large population going through the healthcare usage. But healthcare not only is it shift work, which we know is a risk factor, but you mentioned stress. The work associated with healthcare, the stressors associated with it, epidemic. The violence that healthcare workers experience, way, way above the national average for most jobs. And that's either from patients, from caregivers, from violence that spills over into emergency rooms, from coworkers even. Incivility in healthcare, widely studied and evident. Other office-based jobs tend to be a mix. While they tend to be sedentary, those workers tend to have a little bit higher income, which gives them more flexibility. They tend to have a little bit more what we call control or latitudinal decision-making in the work, and that sometimes balances out the stressors that might come from the office-based type of work. But it's a great question. I really love this quote. My father had one job in his life, Yeah, my father had only one job in his life. I've had 6 in mine. My kids will have 6 at the same time, right? So this gets to that gig economy where people don't have one career, certainly not one career for a lifetime anymore. In fact, if you look at the average of expected jobs in a lifetime for someone now entering the workforce, it's 11 jobs in their working lifespan. Maybe even more, but because that data is a little bit outdated. But my kids will have 6 at the same time, I find quite interesting. My guess is there are people in this room who have more than one job already. That's quite common. Maybe up to half of workers will have a side gig or spare job or seasonal add-on job. But the number of workers who don't have one full-time job, but piece together, the Uber driver who does package delivery for Amazon, who might have seasonal employment in retail or fast food, that's really a commonplace occurrence now. In fact, there are some estimates that, and this is data from 2005 to 2015, that the vast majority of new jobs created were non-standard jobs, not the 40-hour week with take-home benefits, traditional benefits that most people have from a standard employment. Largely that's because many new jobs that were created in the retail environment or even to some degree in manufacturing, but quite common in retail and service industry jobs that were 30-hour or less jobs per pay period. You probably have family members who are not given 40 hours but are given 30 in their regular employment. They would probably consider it their main job, even though it's not 40 hours a week. And that's oftentimes because companies tie full-time employment with a host or a string of other benefits. And if you look at what are some of the health impacts of these non-traditional jobs, lack of benefits, lack of full benefits is a big one. You say, well, there are other options, right? People have other access to health care, maybe through a family member, maybe through a parent if they're under age 26, maybe through an Obamacare plan or an expansion of Medicaid. But we've shown quite a few health effects of not having insurance related to your employment. And it's not just that you'll be spending more out of pocket or that you might delay health care. If you look at longevity of people insured versus not, in some subsets of the population, lack of health care benefits strongly related to early death. So if you're a Latina woman in this country without health care benefits, you will die 10 years sooner than the average woman who has health care benefits, regardless of age. So 10-year life shortening just from the risk factor of not having health care benefits. So it's a pretty significant, powerful, component, asset, if you will, when it comes to health outcomes. Some of those other risks, though, I think are important from a safety perspective. Oftentimes people who are brought on board not as a full-time employee of an organization, but a contractor or short-term worker, a term worker, they are given the most dangerous jobs in an organization. So oftentimes the most hazardous work is outsourced to the part-time worker, the subcontract, the multiple subcontracts that might be given, say on a construction site, for instance. So the most hazardous work is oftentimes done by those people with the least amount of training, the least amount of longevity, the least number of benefits should something go wrong, the least number of personal protective equipment provided. That's commonplace. And if you look at a lot of the OSHA citations, they're at contractors and subcontractors from a big company, not the big parent company itself, who might have the big contract to build the building, for instance. That is a common scenario that we're seeing play out. And no doubt about it, the most hazardous work, the highest number of injuries, tends to be in non-traditional work. We're also seeing this great skills divide, where people with skills are in high demand and they benefit from a gig economy because they can quickly move from job to job to job and get more money, right? So if I'm an IT programmer, I may love the fact that I get to work 6 weeks at a time, because in 6 weeks I'll be able to renegotiate perhaps for a higher wage. Or I love the flexibility of being able to work 6 weeks, make some good money, and take 2 weeks off whenever I want. So there are some people who probably likely benefit from this. They tend to be those with the highest level of skills and the jobs that are in highest demand. Those people who suffer from this kind of tentative nature, sort of precarious form of employment, they tend to be quite stressed and benefit poorly. Intermittent work, strongly associated with lower income over the course of a year, over the course of a working lifetime. Intermittent income, also related to high levels of work stress. Can you guys imagine anything more stressful than not being sure if you're going to get a paycheck 4 weeks, 6 weeks from now? Your mortgage doesn't work that way, right? Your car payment doesn't work that way. Your phone bill doesn't work that way. Most people need secure employment as an important component of living, fulfilling a healthy life. So we're quite concerned that how people are employed is becoming as important in some settings as what they actually do day in and day out. There are a number of challenges that low-wage workers have. So I just put this up, not to go into detail, because these are probably apparent to most of you, but to make the point that when you're intervening around total worker health issues, this is where most of the emphasis should be. If you have the opportunity to only do a handful of interventions or spend a little bit of money to improve working conditions, this is where it should be done. This is where you will get the biggest bang for the buck. This is where you'll get the quickest return on investment, because this is where the majority of health risks lie. Not only because wages are translatable into health dollar for dollar. If you make more money, you're going to be healthier in this country. That's a universal fact. So just increasing wages is the way you lift all boats. That's the one thing a company can do to intervene to improve health, improve wages. Now, I know that's not practical in every setting, but if you want a quick fix, that's it. You will improve safety outcomes and you will improve health outcomes without doing another thing. Just increase wages. That's happening from market forces now. So we're hopeful that we'll see some health improvement related to that. But let's say you instead have a program that you want to introduce. Maybe it's around workplace flexibility, better supervisory training. Train those supervisors who manage your low-wage workers. That will be a much better investment than training all your supervisors. Change working conditions, opportunities, perhaps supplement, meal time, supplement other benefits for these workers. You will have a much better bang for the buck than if you apply an intervention across every single worker in the space. So it is okay to intervene differentially across a workplace. This is the working definition of total worker health, and I'll just pull out 2 parts. You already really know what it is. But the goal is to protect people from those safety hazards they face, but don't stop there. That piece sends people home at the end of the day with the same level of health they came with. They don't go home with fewer fingers or toes or health deficit. That's the requirement of a safe workplace. But if you want to impact the overall health of those workers, add to that. Promote injury and illness prevention efforts. That's how you're going to advance. That combination is how you're going to advance work quality. Keep workers safe. Bring in those 3 Ps, policies, practices, and programs that grow health, some of which we've been talking about. Create worker well-being. We had to have some metric at the end to say, well, how are we making a difference? So we needed to find a way to better measure worker well-being. And we'll go into the tool that we're developing to do that. Obviously, this builds on the NIOSH's foundational requirement to make workplaces safer and healthier. That's part of our name. It's part of the OSHA Act of 1970 that created both OSHA and NIOSH at the same time. We have a mandate to help to keep workers safe. But it really builds upon that, broadens our understanding of all these other things that we've been talking about and their strong influence on health outcomes. It puts a higher focus on better design, higher quality work. We do this integration system approach where we say all of those parts of an organization that impact safety and health should be in the same room regularly, integrating their services and approaches. We view participation by workers as strongly important. If you've got a problem to solve in a workplace, the people best able to solve it are those who are impacted the most by it. So having strong worker input in any kind of workplace design, workplace health promotion program should not be top-down. It should be driven by the bottom up. And some of our research really shows a huge importance of the participatory effect. If you want people to engage in a program, whether it's a new safety process, a new training process, a health promotion intervention, it isn't if we build it, they will come. It's if they build it, they will come. So that participatory approach is extremely important. We talk a lot about interventions. Where are these coming from? Where are our recommendations coming from? We fund 6 academic centers around the country to do this research. I'll show you on the map where they are. And we have 50 total worker health affiliates around the country, including 3 in this state. So Western Kentucky University, Northern Kentucky University, and the Kentucky Injury Prevention and Research Center, are all Total Work Health affiliates, and we're just so appreciative of the work that Cecilia and her team and others are doing across the state. We really appreciate that relationship. All of you in safety have seen the traditional hierarchy of controls, and we've applied it to the total worker health model. I understand Cecilia teaches this in one of her classes, so it really is a good step-by-step way that you can help an organization introduce total worker health. We give great examples, and what I really like about our website is we've probably got more than 50 case studies that describe how companies have done this, how they've actually moved from their traditional way of doing either health promotion or safety to an integrated approach. We're featuring an Well-being intervention for older workers that not only increases physical activity, intervenes for the commonality of arthritis in those workplaces, but has introduced a new vacuum package lift system to help with some of the ergonomic and musculoskeletal components of their workplaces. In just the first few years, they've saved a tremendous amount of money in package handling in their warehouses. Here are the 5 essential defining elements of total worker health. We've touched on almost all of these, certainly leadership buy-in and commitment, design of work. So again, work design being a very strong way you're going to influence health outcomes. Worker engagement, so that participatory approach that we talked about. What about this idea of confidentiality and privacy? Some of the earliest critics of the total worker health approach were if you're going to mix personal life and home life, workers are going to give up a lot of their private health information. Or some of the labor unions said, oh, I don't want the supervisor knowing I got high blood pressure. Understand that. So we've designed ways, we have quite a few recommendations on our website about how you ensure confidentiality and privacy. Perhaps the most important is almost all the health interventions that beyond the required safety interventions, but almost all the interventions we would put forward really should remain voluntary in nature. We think that's perhaps the bedrock of successful programs. There are an increasing number of conditional programs that employers are putting in place. In other words, if you want a lower premium on your health care insurance, we want you to do X, Y, and Z. We find some of those problematic. There's also not a lot of evidence base that kind of forced decision-making makes a significant improvement in health. So we again would argue that voluntary-based participation in health-related programming is an essential component. But building in that autonomy, building in that voice. The other way you get around this is, again, have the workers themselves build the program so that it is most responsive to their needs, and they're also far more likely to engage. And then this integrated element, bringing all those parts of the organization together with one thing in mind. I mentioned well-being is our metric of most interest, and I promised today to give you a little bit of insight in how we develop the measure of worker well-being. Not because you're interested in maybe the research or the mechanics of building a national survey, but perhaps because I want you to see the value of this in your own organization or in those that you advise. So this metric is about a 17 to 20-minute survey that will be done in workplace settings. It can be done free of charge. It'll be available on our website in February. You'll be able to download it and use it in any kind of setting, small organization, large. And it will measure 5 different domains of worker well-being. Why 5? Our research shows that these are the 5 most influential areas that are impacting the well-being of workers. But better news is the results of this survey will allow you to see which of those 5 areas you need to intervene in. Maybe you're doing great in 3, and you have 2 that really need work. So it will help further define where you should intervene. And then the tool will also give you some guidelines on how you use the results and how you improve the well-being of the workplace. So those 5 domains that we cover are what about the physical environment and safety climate? So there's a handful of questions that get to some of these issues around hazards and exposures, workplace safety, physical working conditions. How important is that in the well-being outcome of the population? Could be huge in construction, maybe not so much in office-based work, right? But this kind of tool will help differentiate that and help you determine where your dollars are best spent when you're ready to intervene. What about the work evaluation and experience? How do you get along with your supervisor? What's the psychological climate like? You know, we're one of the few developed countries that doesn't have a psychological workplace standard. Almost all countries, certainly the UK, many in Europe, Australia, Canada, have OSHA type authority mandated psychological standards in the workplace. We don't in this country. And there's no hope likely in the next short term that we will. But those have made a dramatic difference in workplace stressors, in some of the challenges that workers face around incivility, bullying, guarantee of higher quality working relationships with coworkers and supervisors. What about the policies and culture? This includes things around salary compensation, discrimination, other organizational policies. We put this here because we think it's pretty powerful. If you want to change the behavior of one diabetic at a time, you can do that. It costs a lot of money, and you will have very slow success. If you want to change something like whether or not a huge number of people smoke on the job, introduce a tobacco-free policy. The research shows that that dramatically drops the number of smokers you have in your environment. Yeah, it's true, some never come here to work. But a tobacco-free policy absolutely changes the percentage of workers who smoke. For one thing, it shows them that, okay, I'll go out and get some nicotine gum for those 8 hours I work, but it shows them that they have other options to tobacco, and it gives them confidence. Hey, if I can go 4 hours without tobacco, I can go 8, I can go a full day, right? So tobacco-free policy has a number of downstream effects. Again, we put policies in here as an important, strong component to change the dynamic. This piece gets to, what about that worker's individual health status? How does that contribute to their overall worker well-being? We have a number of questions in the tool that will get to that, looking at physical health, mental health, their injury history, really powerful component when it comes to measuring worker well-being. And then we're going to look at their engagement outside of workplace. What about their activities outside of work? How active are they? How is their family impacting their interactions with society members, with friends, with the community? What are their activities beyond work and how that contributes to their overall opportunities for work? I expect this may be an area where we'll see some important red flags, especially in those jobs where hours are long, where shifts are common. I bet we'll see huge gaps in the well-being of those workers related to this component. And this may also go on to better explain how workplaces can become more important parts of their community. Workers are part of a community. An organization draws its workers from the community around it. So we believe there's an argument to be made that employers should invest in the health, the safety, the well-being of the community at large. And we'll hopefully be able to make that case. Have any of you heard of the new lung disease outbreak that we're currently studying relating to vaping? Just got an update yesterday. I think there are either 44 or 45 deaths, quite a large number of other deaths that are under investigation and likely to be related as well. And now maybe 2,400 cases of vaping-related lung injury and lung deaths. It is appearing that there's some risk associated with one of the carriers that's used in those people who use sort of street products of THC or marijuana for vaping. So vitamin E acetate, vitamin E oil, is oftentimes a carrier that THC or marijuana psychoactive substance is added to be used in these vaping devices. And it appears that there's a huge association between the number of deaths and the use of that combo of THC and vitamin E. So that appears to be early indication of some cause and effect there. Of course, many of these still under investigation. I put this up here because you can see just a month ago we were at 380 cases in 36 states and 6 deaths. We're 7 times that many deaths just a month or so later. And that's because, oftentimes public health reporting lags behind. When people see a cluster of deaths, then all the states go back and look at their unexplained deaths and start identifying other cases. And that's clearly been the case here. Probably a lot more milder cases that never get reported. So we're probably seeing the tip of the iceberg to some degree. A lot of debate about what the right policy intervention is here, so we'll see where this goes. This is Dr. Howard. He's the director of NIOSH, my boss in DC. He has made it a priority for NIOSH to better shine light on the connection between work, working conditions, work injury, and the opioid overdose crisis. Here's the issue that your state dealt with long before much of the nation. You guys were in the epicenter of this outbreak, this epidemic. And largely, the game changer was the arrival of illicit fentanyl. That's largely responsible for this huge spike in the number of deaths. Now more common to die opioid overdose than motor vehicle crash. Also, you might have heard the state of Massachusetts said that for 2015 and 2016, the most common reason someone dies on the job is not from motor vehicle or a fall from height or struck by. The most common reason people died while they were at work was drug overdose for 2015 and 2016. That was the most common cause of death. That's the only state where that's true, to our knowledge. But this is definitely something that's impacted work. So we believe there's an association between this outbreak and the fact that people don't have jobs. So if you look at where the earliest challenges were, they were in the Rust Belt where there was lots of manufacturing closing, New England where we saw lots of unemployment, Appalachia, other parts of the nation that were really suffering from the economic downturn. So not having a job shown to be associated with overdose death. Jobs that are insecure, that really would fall under this non-standard or new employment arrangement, also related to opioid overdose death. Hazardous work and increased risk of work-related injury. This gets to the point that people are dying of opioid overdose not because they were exposed to heroin by going to, oh, I'm a marijuana user, and then maybe I'll try a little cocaine, a little meth, and then I become a hardcore heroin user. That is not how people are getting addicted to heroin. And then getting exposure to fentanyl and some of these other powerful opioids. The gateway drug to opioid addiction, to opioid misuse, is a prescription opioid. That is by far the most common pathway that people take to an opioid use disorder. So with that in mind, we're very strongly interested in how opioids are used in the post-injury setting when people have work-related injury norms. So we're doing a lot of data mining through state workers' compensation systems to look at what is it about work, what is it about work injury, what is it about prescribing patterns in the face of that will help us better predict where we can have them. There's only one place where all that data, where injury, industry and occupation, and prescribing patterns, healthcare delivery, is in one system, and that's the workers' compensation system. So we're mining that really deeply to find out more and more. We also know that lack of benefits and paid sick leave is a common precursor to opioid overdose death. Why? Because people who have jobs that are either difficult and lead to daily pain will oftentimes take pain medicine to be able to go to work, to report to the workplace. You might have heard about a study out of Miami, University of South Florida, I think, that went around construction sites and collected urine that was left in Gatorade bottles. Hear that story? Quite interesting. Huge number of impaired construction workers. So urine testing showed positive for a number of illegal substances, certainly for people working in dangerous settings. Some of those frightening to see the high level of positive urine drug screens in construction sites. Some people would question the ethics of that study. It did make it through an ethics review board, certainly anonymous, no names were connected to whose urine was being tested, but these researchers just went into construction sites at the end of the day and collected any urine they found in bottles of Gatorade or soda around the construction site. This is an important study from the National Safety Council that basically says the vast majority of employers know this is an issue in their workplace, but they're not ready to deal with it. Another striking one that I found here, only 4 in 10 employers would return an employee to work after he or she was treated or misusing prescription opioids. To me, this is a real challenge for us. If we're going to come up with recovery-friendly, recovery-supported workplaces, we're going to have to change the belief of employers. I think our takeaway at NIOSH is this is a very difficult condition to manage and treat, but it is treatable. With the right approach, this should really be viewed with no stigma, just as diabetes. We wouldn't tell the diabetic, oh, will you come back to work when you've cured that diabetes, right? We wouldn't say that. We would say, yes, you can continue working. We're going to support you. We're going to give you health care benefits that help you manage your condition. We're going to see this as a chronic brain condition that is difficult to treat, but it is treatable. It is recoverable from. And oftentimes the workplace is a place of healing where that kind of treatment and support can be delivered. We developed a research framework that looks at attacking this crisis. First, identifying those workplace conditions that we talked about, benefits, job design, job requirements, jobs that might lead to pain, jobs that might lead to injury, and how we can intervene on that level. What about those risk factors when someone does have an injury or pain? Can we change occupational medicine and other healthcare settings around prescribing? And there's some good prescribing guidelines now that have been put in place to help diminish the risk for that transition between prescription and illicit opioid use. And then sort of the bottom half, quite interesting. NIOSH has been tasked to investigate workplace exposures to opioids, so inadvertent exposures to opioids. Can you imagine a setting where that might happen?
Law enforcement?
Law enforcement, first responders who go into a scene that's contaminated with dangerous drugs, either a drug bust where there might be drug production going on, but we've investigated a number of scenarios where someone has tried to flush down drugs as the space was being entered, and that's caused a plume of potential powders across the room and potentially exposing first responders, police, firefighters, EMTs on the scene as well. There's very little evidence that these drugs penetrate the skin, so that does not appear to be a dangerous exposure. The bigger risk seems to be either airborne exposure, where someone might breathe it in, or touching a surface and then bring it up to the eye, nose, and mouth. That tends to be where we would perceive the greatest risk to be. There's very little research that proves this connection. There's quite a bit of symptoms and even some body cam footage that's shown some of these exposures. It's pretty dramatic, pretty stark. But we plan to do additional research to actually do some biochemistry, some biochemical monitoring of these exposures and to see to what extent these exposures are occurring. It's an area where definitely more research is needed. We're also being asked to help those workers who have to move in to either illicit production facilities or drug bust scenes and clean them up, how you protect workers in those settings. So that's kind of bottom half is traditional worker protection work of NIOSH. The top half is more the total worker health aspect of NIOSH's work. As I wrap up, I'll just give you a couple of resources. I know Cecilia uses this in one of her classes, but this is a textbook or an edited volume on total worker health. It's quite useful reading, though, for the lay reader as well. It's not just an academic publication. It gives some great insights into total worker health from its historical underpinnings, the research base, and good chapters on interventions. It's got a great chapter on the future of work as well, so I invite you to take a look at that. I mentioned our centers of excellence where we're doing academic research. They're in green here. We have them fairly scattered across the U.S., but we certainly wouldn't be objecting to seeing one in this area of the country. So if any of our universities have an interest in applying to become a center of excellence, we have a new competition that's coming around in a year and a half or so, and we look forward to that. And then you can see the total worker health affiliates that are listed as well here, and I have pointed out the three in Kentucky in bigger font, bigger type here at the bottom of this. We really do appreciate those partnerships. The affiliates are sort of our learning laboratories. They're the ones where we're getting our interventions, hearing about success stories, promising practices, putting those on our website, sharing the story. If you're not following us on LinkedIn, Twitter, or getting our newsletter, we would love to get you on board. We have more subscribers to Total Worker Health in Action than NIOSH E-News. So NIOSH E-News is the sort of the headliner 30-year publication of NIOSH. We have more subscribers now to Total Worker Health in Action. And I think that's because we're bringing in fairly applicable, more broad-based suggestions that really impacts every type of workplace, not just manufacturing, not just some of the high-risk places where NIOSH has got a lot of traditional partners. We're really bringing solutions for every workplace, every worker, even those workers that don't have a workplace, right? One of our 6 centers of excellence is studying how you reach workers who are the gig workers, who are the independent workers that never have a workplace. They find their own health care. They make their own schedules. So how do you influence their health and well-being? One of our 6 centers specifically studying those populations, the very future of work related. I'll just close with this. And I hope that you can tie this to your own work as well, because people want to go to work these days, not just to produce a widget or make money. especially, that might have been true for baby boomers, who are very focused on following the rules, doing the work, getting paid fairly, retiring with benefits. Most workers today don't expect that trajectory with one job for a lifetime, retire with a pension. So there's this, what I would call is this front loading of expectations from employment, that they will actually get something out of it from day one, that the work itself will be meaningful, that it will have some of these characteristics, a social good, a social purpose from the work that I do every day. If you ask millennials, they will change jobs quickly if they don't feel a social connection, a social purpose to their work. My guess, many of you in public service, public health, that's a very strong component to your work as well. So I would say to the extent we can build in some of these elements or explain these elements as important parts of the employment contract, I think we'll be more successful. It's also striking that a lot of these things have known documented health effects as well, like autonomy that we've been talking about, that flexibility built in there. Rewards and recognition, a huge amount of human resource literature and study that shows appropriate rewards and recognition, vastly underdone in this country, so important to people's engagement with work. So we're doing all we can to tie these issues with health outcomes to better study and better understanding them, so new designed jobs, new future jobs will have these kinds of elements built in. There were 3 workers in the distance, clearly doing some type of construction. Walk up to the first, tell me what you're doing. He said, well, you can see, I'm putting one brick on top of the other. I'm a brick mason. I asked the second one, what are you doing? He said, I'm making $20 an hour. I'm really well paid for this. I'm happy that I'm getting paid $20 an hour, taking it home to my family. You asked the third worker, clearly doing the same thing the other 2 were doing. What are you doing? I'm building a cathedral where my children will be married and my grandchildren will be christened. All 3 people doing the exact same thing. One of them had found meaning in his work, her work, had engaged at a different level with that job. Good supervisors and managers find the way for people to make that connection. That, we believe, is a strong component of producing better jobs, producing better health opportunities for workers. So, on behalf of Willie and me, let's go find that meaningful work. Thank you. Time for questions or not?
We've got fun.
Sure.
Plenty of time.
Happy to answer any questions you folks have or talk with you during the break. I'll be here until lunchtime, so happy to be with you. Hi.
I just had a question on the slide that you had about the obesity rates for different groups.
Yeah.
So EMTs were down in the group with physicians and dentists, where I would think they would be up there with the police and firefighters and emergency.
Yeah, it's interesting, isn't it?
Is that based on NAICS codes or?
It is based on NAICS codes.
Okay.
The other thing is, I'm sorry that I can't find that right away, but we'll eventually.
It is pretty far back.
Yeah, it was at the beginning. Partly it might be artificiality from NAICS codes. The other thing it may get to is that some of those jobs, if you compare a police officer sits in a patrol car the vast majority of their time, they may not have a job that's as physically demanding, right? But there's a paradox between physical activity and obesity. If you look at some of the most active jobs, and a good example is low-wage healthcare workers that do patient lifting and patient bathing, and they're constantly moving and lifting, they have high rates of obesity. Hotel housekeepers who do bed changes and vacuuming and cleaning, high rates of obesity. So there's this paradox that some jobs from sedentariness cause obesity, and some jobs that are quite physically active also tend to lead to obesity. That tells us that there's a stronger influence at play other than physical activity in producing obesity. That's why it may not be always the go-to solution is to get people more active. Some of the researchers in Europe have called it the Goldilocks principle. Too little activity is not good, but too much activity can also predispose to obesity as well. And how that mechanism is, the exact physiology, it may relate to the fact that people are too exhausted to engage in meaningful physical activity after work, or that they overeat to compensate for that high level of physical activity. But So I don't know how that applies to EMTs, but I also found that to be quite a paradox there. Question?
What's the training of employers that respond to total worker?
Great question. So how much uptake are we getting in the nation? What are employers saying about this? This is perhaps the fastest growing program within the NIOSH portfolio. And I mentioned that the NIOSH News has 70,000 followers. We have 80,000 followers that want our information and are getting our information as it comes out. So we've got a good trajectory of uptake. We went from 2 centers of excellence doing this research to 6 over the last decade. We fund about $100 to $2 million per center per year. So it's a relatively small investment that NIOSH makes. But we're getting quite a bit of public recognition and buy-in to this approach. If you look at uptake in Fortune 500 companies, I would say we're seeing good uptake in the energy sector. So Chevron, for example, is a good example. Shell has some programs. Healthcare, pharmaceuticals, manufacturing, Dow, Johnson & Johnson, we've got some projects underway. Some manufacturing, GE, near our Cincinnati laboratory, we've got some projects underway. Small and medium-sized businesses, so that's where a lot of the risks are and where a lot of people are employed. So we're putting our emphasis beyond just the Fortune 500s also. I mentioned 6 centers, one doing work with gig workers and people without a traditional employer. One of our other 6 centers is in Colorado, but it's focused only on small and medium-sized businesses. And they're using sort of a train-the-trainer model where they will say this, if you will, employer's total worker up certified. And they're coming in with assistance and metrics and measures to help a workplace become certified to do this kind of thing. We think, though, the big next step is what people are starting at the university setting to do, is to train that next generation of safety professionals who understand what this intervention is. That's why we have the textbook that I just showed you, and it's why we're developing new courses at universities, both at the undergraduate, graduate, certificate level. We even have a PhD program underway at UT Houston, because we think this to catch fire, we need to be turning out occupational safety net professionals who understand this kind of connection, and then carry it with them into their employment, wherever they go. So that's sort of our trajectory to get this buy-in, even more so than we have today. Thank you for that. It's a really helpful question.
Going back to this slide, this is really interesting. I'm wondering if you have this for other things like smoking by occupation or control
Physical activity by occupation,
physical
tobacco.
activity. Do you have those kinds of things?
We absolutely do. This is a graphic that uses information from BRFSS and the National Health Interview Survey that was in, I believe, the Wall Street Journal. But there is a query tool on the NIOSH website called Worker Health Charts. And it will allow you to put in any industry and occupation. And we have 10 sectors in the economy that we do most of our research under. Manufacturing, healthcare, social or services, transportation and warehousing, public safety. We divide out into 10 sectors. Some of the charts will allow you to break it down into even subsectors within those 10 sectors. But those worker health charts allow you to bring up a number of major health impacts. Heart disease is one, cancer is one, tobacco is one, obesity is one, a few others. It's not as granular as we would like to see it. We'd love, obviously, more details, but it's a start.
So this may be too loose of a connection here, but what your chart where you talk about family, community, that piece,
Right.
is there evidence around companies that have things like on-site daycare or flexible family leave policies that those support that piece?
Yeah, this whole sort of connection between work and family and work and community and how important that is in health effects and health outcomes. I mentioned that 30-year program in work stress. One component of it, and 2 of our total worker health researchers are specifically looking at this connection between work and family. And supportive policies around that, extremely important. And they've shown health impacts of that. What they haven't shown is a lot of return on investment or economic outcomes related to that. But clearly, worker engagement, worker satisfaction, retention, worker stress decrease when you have all those policies in place, absolutely a good evidence base for that. And we would argue that those kinds of worker, family-friendly, worker community supportive policies are absolutely, there's good science behind why they are effective. So I would absolutely say yes. I don't know specifically if on-site daycare was one of the elements measured, but just policy friendly to family and to community in general, that's absolutely a good study.
Thank you.
Yeah.
Just to kind of piggyback off of his comment as well, I guess I have seen and heard in the news that there's a lot of information regarding home and family balance, and companies now going through and looking at 4-day work weeks versus a 5-day work week. Have you all also had that in your mix in terms of what you have found? Has that actually been beneficial, or?
Right. Yeah, I'm not aware of internal NIOSH research on that, but some of the NIOSH funded research specifically looks at work shift length, work hours, and its correlation, to fatigue and other health outcomes. Specifically moving from a 5-day to 4-day work week. I think just in the late press there was something this week about how decreasing the number of hours from 40 to 32, which would basically be a 5 to 4-day work week in setting, decreased productivity almost by none at all. Productivity was absolutely about the same. Yeah. Now, my guess is that it strongly depends in the setting, right? If it's manufacturing, obviously that might not be the case. If it's the office-based worker, where the type of labor is quite a bit different, then that you might expect some of those outcomes. In healthcare setting, that would be a very difficult translation to make, right? So I think that's highly variable from industry and occupation.
I think I saw some research that, or maybe it was on the news or the internet, where office workers were given, I think they were IT workers, given the option of 4 10-hour days, and the productivity increased like 30%.
Interesting. Yeah. Wouldn't be a surprise.
And
Again,
they picked the Friday or the Monday
sure.
to be off, but they said it actually increased productivity significantly.
Yeah, my recollection of that was that they they just went from 5 days to 4 and did not change the day shift.
Well, I think they had, they
It could be
increased the
both.
length of their workday.
Yeah, interesting.
We have time for about one more question.
Perfect. One more question. I really love these questions and giving us some great ideas too on how we can improve our messaging. Hi there.
So I'm still a student, but I guess my question is like I'm a full-time student and I work full-time to keep my benefits. Is there anything that you guys study for younger workers who are in school who also have to keep their benefits, be able to pay their rent and stuff like that, like the stress levels that come from
Sure.
doing a million things at one time?
Yeah, unfortunately, it's happening as a student, but I'm sure people in this room can tell you that may be happening later in life as well. I would say the vast majority of our work in this area is looking at shift length, workers, shift working, so working at odd hours, and then fatigue that comes from long hours of work. And we have a number of great researchers who are prolific, just churning out the research related to those 3 topics, and those would certainly apply. We also think that one of the downsides of this gig economy is that for every job you increase, you double the transit time between jobs, right? So not only do you have more working hours, but you have more time spent commuting to and from work, and that's not tiny in some settings. So that's a further drain on personal time, personal freedom, flexibility, time for better choice making, that sort of thing. Time for social connections, family connections. So we clearly see, regardless of where it's arising from, this connection between long hours of work, fatigue, work stress, and poor health outcomes. No doubt about it. Great. Thanks again, folks. Really enjoyed being with you.